Hello, and welcome to Mental Health Matters. I'm Edgar Wiggins, Executive Director of Baltimore Crisis Response Incorporated, and your host for this show that is dedicated to providing you with practical and useful information regarding mental health issues and needs. For some time, there's been tremendous concern about mental health issues in children and adolescents. Today, to try and help us make some sense out of these challenging situations, we have with us a guest who has come to share her expertise in this area. We have joining us here in the studio Dr. Paramjit Joshi, who is a child and adolescent psychiatrist and is an associate professor of psychiatry at Johns Hopkins. Welcome to Mental Health Matters.
Well, thank you very much. I'm delighted to be here.
Let's kind of get started with our discussion today by talking about some of what we see as the common mental health problems or the common mental health concerns that we see in children and adolescents.
Well, perhaps a quick way to divide mental health concerns would be children who have externalizing behaviors, if you will, and these are behaviors, which you would pick up very quickly, a parent would pick up very quickly, and a teacher, such as trouble concentrating, such as behavior problems, or being impulsive. These are things that we readily see in children, and so these are external behaviors that we pick up very quickly. I think where we run into trouble are symptoms of mental disorders in children and adolescents that are internalizing behaviors or symptoms, such as sadness and other feeling states, or anxiety, obsessions, compulsions. And so this is a way to help parents understand externalizing behaviors and internalizing behaviors and symptoms.
Well, when you talk about externalizing behaviors, you are, if I'm understanding you, talking about the kinds of things that children do that really call attention to them.
That's correct.
If a child is impulsive, if a child is fighting and has trouble getting along with others, the kinds of things that result in academic performance problems like poor concentration and so forth. Those things are certainly pretty readily apparent. Now, in terms of these internalizing things, and you're talking about sadness and anxiety, I would guess that children might have some trouble expressing those kinds of feelings, and certainly directly expressing them.
And there's no question about it, especially the very young child. They have trouble with vocabulary. They just don't, they know how they have the feeling, but they don't know quite how to describe it. And so if you ask a 6 or 7 or 8-year-old, they'll say, I'm sad or I'm angry, but there are lots of other sophisticated feelings that we all have, which they have a hard time describing. And so, which is why, actually, as a child and adolescent psychiatrist, you have 2 years of extra training to learn how to be able to communicate with children and adolescents to help understand how they may be feeling. And, for example, a depressive disorder in a child and a depressive disorder in an adult, even though the symptoms that we look for are the same, the way they present it is quite different. And so you need to know, how to go about asking a child about a mood disorder.
Well, let me ask you a question, because the one thing that's pretty apparent is that if an adult is experiencing a mental illness, and they can put that into words and say that they can talk about the change that. All of a sudden I'm feeling sad, I'm finding myself feeling perhaps moody or irritable, I'm getting tearful, I'm having trouble concentrating. Those are very clear things that the professional can then say, okay, and begin to think about how to diagnose this. How do you ask a child about those kinds of things? What kinds of things might a parent be able to do? Because when I think about it, for instance, one of the things I think about, even in terms of my own children, is how quickly their moods change. Child's happy one minute, sad the next,
Right.
irritable one minute, angry the next. I mean, how do we begin to understand? Because one of the things we're trying to help parents do is know when it's appropriate, perhaps, to get that professional opinion.
And you're absolutely right. And I think one of the important things is that it's very seldom that a child will seek for help, because they won't even know that something is wrong. So it's always either the parent or the extended family or the school teacher who will bring attention to the parent. I think your child is having some difficulties, or so the reason a child is brought to a mental health professional, if you will, is not because the child says, I really need help. It's always an adult in the child's life, whoever it might end up being. And when it comes to a depressive disorder, I think what you look for is a clustering of symptoms that occur all at the same time. And you're absolutely right, Edgar. All of our children at some point in their lives, have had trouble sleeping, or with appetite, or they're irritable and moody. And I think the question that most parents have is, what is normal moodiness of adolescence?
Right.
And when does it become a mood disorder?
Right.
And of course, I think when I look at a child in my mood disorders clinic at Hopkins, what I'm looking for again is a family history, because really a mood disorder tends to run in families. We do know that. So it's really important to take a very detailed family history. And often what will happen is, I'll have a child who comes for what I call a well baby check.
Right.
It's because either a mother or a father or someone in the family suffers from a mood disorder. They have learned along the way that it does tend to run in families, and automatically they worry about their child, like you would, if you had, say, diabetes in the family.
Sure, exactly.
And it tends to run in families. And so I call them well baby checks, and I'm always very pleased when a parent actually does that, because they're thinking ahead, and they're trying to access the right evaluation for their child, and I think that's important. So getting back to when do we say it's a disorder as opposed to kind of the normal variances of just growing up. If there's a positive family history of mood disorder, we know that the child is at risk. There is no question about that. Whether the child eventually develops it, is a different story. But so that's kind of a risk factor. As actually with attention deficit disorder, we do know that tends to run in families as well, as is anxiety disorders, as is an obsessive compulsive disorder. So I think it's really important when you do a comprehensive evaluation is to take a good family history. And a good family history is not, Edgar, does anyone in your family suffer from a mental illness? By and large, the answer will be, I don't think so. And that's what I call a bird's eye view family history, which is really useless as far as I'm concerned. A good way to take a family history is, you identify each person in the family, because then what you're getting the parents to do is to focus on that person for those few minutes, and then they can actually just think about that particular person and say yay or nay, or whatever it may be.
Well, one of the other things that strikes me as well is that when you ask a kind of broad, it seems specific, but it is a fairly broad, does anybody in your family suffer from a mental illness? There are things that, depending on how old the parents are, that we now recognize are in fact indications and symptoms and behaviors of mental illnesses that perhaps, 20, 30, 40 years ago, we weren't aware of that. And the parent certainly may not be aware of that as well.
Right.
So I think that you're hitting on something that's important. It's essential to get sort of an emotional barometer of what the household was like, is like for the people that are living in that household.
That's
and
correct.
if we find that, for instance, there are these great changes in mood, then perhaps it's almost like we're doing kind of a retrospective assessment.
That's correct. That's correct. In fact, many times what happens is that we diagnose a certain mental illness in the child, and as you go into the details of it with the child, the parent will say, that's the way I felt when I was young. And it's kind of the backdoor approach to diagnosing mental illness in another family member. And it happens oftentimes.
Well, let me stop you there, because I think that this is extremely important, because one of the other things that strikes me is that although we know there have been some tremendous advances in terms of treatment and psychiatry and community mental health and so forth, we also cannot ignore the tremendous issue of stigma. And so that the further back we go as we try and learn about the families and the family histories, the more we also have to consider that issue because we recognize that stigma is alive and well, and it really is a deterrent to people getting the help that they need.
And there's no question, if you recall, many years ago, cancer was a stigma. I remember growing up, or when I was in medical school, it was kind of a scary word. People would say everything else except I have cancer, and then we went to I have AIDS, and the same thing applies to a mental illness. And I think we are much further along than we were even 20 years ago when it comes to the stigma issue. And I think we're all human beings. So when we have important people that we look up to, say like Tipper Gore came out and said, I suffer from a depressive disorder. I think it gives people permission to say, wait a minute here, this is somebody really important. It's, when Ronald Reagan said, I have colon cancer, and then suddenly there was, kind of colon cancers coming out of the woodwork.
Exactly.
And so I think that people that, we look up to, celebrities and just important people in our lives, I think they do a great service when they are able to share.
Well, I think that we're certainly moving in the right direction. I know we've got a lot more to talk about, but we do want to take a short break, and we'll be right back to Mental Health Matters.
This is the story about a group of kids who volunteered.
Doing something nice for someone. We fixed stuff. Did some art projects with the kids. We fixed up his house. We worked in the woods. Cleaned up the park.
Did something for the planet.
We just did it.
No other reason. And you know what? It was great.
At first, they didn't know each other.
Well, that didn't last long.
This guy is really funny. Me?
Ace are my new friends.
Are you into it?
Call 4-H or check out our website at areyouintoit.com.
In nature, we see reflections of our children. The tree is the strong one, the ocean rambunctious and untamed. Like our children, each brings something wonderful and unique. They add color, they bring life. And to choose the sky over the water would be like choosing one child over the next. EarthShare, the world's leading environmental groups working together. To learn how you and your employer can help, visit our website.
Welcome back to Mental Health Matters. We're continuing our discussion regarding child mental health issues with Dr. Joshi, who is a child and adolescent psychiatrist and an associate professor at Johns Hopkins. Now, before our break, we were talking about how parents and other caretakers can begin to recognize that there are problems that may, in fact, need the evaluation of a mental health professional. Can you say a little bit more about that?
Well, when you look at a child's life, there are really three domains that we worry about.
Okay.
There is the social life, which is really important, because we know kids, have big peer groups and whatnot. There's the academic life, which actually amazingly is the only part of a child's life that's monitored quarterly, if you think of it.
Right.
And then there's family life. And going back to the academic life, there's a report card at the end of each quarter.
That's right.
So when you look at a child's life, right from kindergarten all the way actually to college, through college, or even graduate school, there's a report card that comes home. And we always worry about our kids' grades, and so if there's a dramatic change, the child was doing fine and suddenly the grades are falling off, and you're getting calls from teachers, which is quite unusual for your child to kind of experience something like that. It's a red flag. And in the home life, if the child is suddenly, I can understand teenagers not wanting to hang out with their parents. I mean, that's okay, it's developmentally all right. But if the child is also not wanting to take phone calls from their friends, not wanting to hang out, socially, friends are calling and they don't want to respond, something is not right.
So you're talking about a child really isolating him or herself.
Exactly. And so when you see a child who's not participating either in the family life or in the social life and falling off the tracks academically, for me, I think the child needs an evaluation. Something is not right.
Okay. Now, when we're looking at children's mental health issues, one of the things that we talked a little bit about earlier was this idea of sadness and maybe fears and changes in mood. But how do we really focus in that there's a problem? Because children have fears, children have changes in
Correct.
moods. I mean, what takes it sort of over the line where we're thinking about a mental health issue?
And again, it goes back to, you have a clustering of all of these symptoms. For example, if you take worries, most kids worry a little bit. We all worry.
Sure.
It's just a normal human experience. And I'll ask the child, do you think you worry more than most kids your age? Because you're trying to make a comparison. And
Right.
that's not just in its, in a vacuum. There are other things, they're having trouble sleeping, or they're having trouble with appetite or concentration, or, they're just not having fun, in things that are normally fun for them. So, you start to say, there is something here, and it needs an evaluation to try and figure out, is this a mood disorder? Is it an anxiety disorder? Is it an obsessive compulsive disorder? Or is it just, a little, it doesn't really kind of fulfill all of those criteria, but it's a little more than normal anxiety.
Right.
And then, as grown-ups and as we always find reasons why our kids feel a certain way. You and I always do this.
Sure we do.
Oh, honey, you must be feeling sad because you didn't get a Christmas present you wanted.
Right,
And so somehow we always answer for our kids. And sometimes, we actually miss something that's more serious because we find an answer for how the child may be feeling or behaving or whatever it is.
So we really need to, as parents and caregivers, we need to ask and listen for the answer, not supply the answer to the child.
Exactly.
Because one of the things that, we certainly recognize is that if we have to deal with a child's mental health concern, it also makes us uncomfortable.
Right.
We begin to wonder if we're good parents, if we're good caretakers,
Right,
have we
right.
done something wrong?
Right.
There's a lot of the old traditional psychodynamic literature that talked about poor parenting as the problem. That's at the root of this thing, and so we become afraid that we're going to be criticized and we haven't done a good job, when we recognize that, as you said earlier, there are real genetic predispositions, things run in families, mood disorders run in families, mental disorders like physical disorders run in families, and that's nobody's fault.
No, absolutely not. In fact, there's a patient of mine who said, Dr. Joshi, I didn't do anything. My parents didn't do anything. This is something that came to me. I didn't go seeking it. And I thought, that was really a very articulate way to describe this. Just like we have, say, diabetes, epilepsy, or heart disease.
Right.
We don't say, this just happened. It's not something you wish for.
Right.
It's something that came to you, not that you
Right.
did yourself or your parents did.
Right. The other thing that I think is important is that we also recognize that these genetic predispositions, if you will, these things that are inherited and passed on in the families, also have a way of showing up at times when there may be stressful events in life, there may
Absolutely.
be changes in life, and so forth.
And I'm glad you mentioned that, because just as any other stress can precipitate, say, ulcerative colitis or a heart attack,
Sure.
so can stressful events. And for children and adolescents, it's really, separation of parents, a
Right.
move, a different
Right.
school,
Right.
going away to college, and I call good stresses and bad stresses. There are good stresses in life too, like getting a promotion, getting married, having a child. These are good stresses.
Right.
But they make you more vulnerable. And so if you have a predisposition, it kind of brings it to the surface.
Right, right. Well, let's talk a little bit about one of the other things that we see a lot that's a concern in terms of especially adolescents, but even now in younger children, is this idea of substance abuse and how that fits into the scheme of things in terms of mental health concerns.
Well, it's a huge concern for all of us, because, we always worry about our kids getting into the wrong peer group. And, worrying about, if you talk to parents, there are two major concerns these days. It's exposure to violence and it's substance use, whether it's alcohol or drugs. And unfortunately, some of the kids, as we were talking earlier, they know something is wrong, but they don't know what it is. And parents perhaps haven't quite kind of figured out what it is either. And the kids want to feel better.
Right.
So they self-medicate is what I call it, and so they resort to alcohol or they resort to drugs when in fact they have an underlying mood disorder or anxiety disorder or one of the other internalizing disorders. We all want to feel good.
Yes, we do.
And so what happens is now they have two problems to deal with.
Right.
Not only that, they have an underlying mental illness, on top of that, they've added more problems by now resorting to alcohol and drugs.
Well, one of the things that we also have been extremely concerned about with not only children and adolescents, but also adults, is the degree and extent to which substance abuse makes people more impulsive, makes people more likely to do things that if they were not under the influence of these substances they wouldn't do. So that, we know, for instance, in terms of completed suicides, that 70% of people that have taken their own life did it under the influence of some substance. We know that domestic violence and abuse, often the perpetrators of those kinds of things are under the influence. And so we also, I think, have to be concerned about adding to the risk of suicide, adding to the risk of violence. Can you talk about that just a little?
Well, I always tell parents to have a depressive disorder, to have substance and alcohol use, and to have access to firearms is a lethal cocktail. It truly is. And not that every child who is suicidal necessarily has an underlying depressive disorder, but every child who has underlying depressive disorder is much more vulnerable to have suicide, and we really need to take it very seriously. And so what happens is, if they resort to alcohol and drugs, their judgment is not.
That's right.
I mean, it's impaired in two ways. It's impaired because of their mood disorder, and then on top of that, it's impaired because of they're under the influence. And so, they're not using all their faculties and their coping skills. It's impaired.
Well, one of the other things that has come up, and it certainly has gotten a lot of press as a sensational kind of thing, but I don't know that there's been as much as I would like to see in terms of a more serious look at this whole issue of teenage suicide and even suicide in children. When I came to Baltimore, right before I relocated here, just about 12 years ago, I'm from Philadelphia, and I used to work on their suicide and crisis intervention service. It's a telephone service very much like the one we've set up here, Baltimore Crisis Response. And one of the last calls that I took in that job was from a 10-year-old who called very upset and distraught because her 10-year-old friend had warned every adult that she knew that she was going to kill herself. And this, apparently, warnings had gone on for 2 weeks. And I suppose that no one took them seriously because the child was found hanging by a belt in the closet, had killed herself. And at that point, that was the youngest suicide that I had heard about of a 10-year-old. And of course, as time has gone on, we've heard more about suicides of younger and younger children.
That's correct.
So it really is, I think, a major concern.
It's a very serious matter, and which is why it's really important that if in fact the child has a treatable disorder, we need to take care of it, so we can avoid, them getting so hopeless that they think of ending their lives.
Well, let's step to treatment a little bit because we're familiar with the kind of counseling that happens either individually or in a group. Sometimes families need to get involved in counseling because there are family issues. There's divorce, there's separation, there's marital discord. I mean, there's all kinds of things. And we're kind of familiar, I think, with this idea of talking things out. But one of the things that folks, I think, need some information about is the idea of children being on psychiatric medication, what the medications can do, what we can expect from them, and what we can't expect from them.
Again, going along with the stigma issue, it's, the parents have come this far. Okay, my child has a mood disorder. And then the next thing you say is, well, the child needs a comprehensive treatment package. And what does that consist of? I believe that the children need to know what they're suffering from, because if they don't, they are poor patients in terms of compliance. Often with mood disorders, there's use of medications. And the way I explain it to parents, because you'll always get this hesitancy. My goodness, why? That's really bad. It must be really serious. And my usual response is, if I took a throat swab and you had a strep throat, and I said, and I was a pediatrician, and which I used to be. I used to be a pediatrician, and I'm prescribing penicillin. What would your response be? And they'd say, well, my child needs penicillin. And I said, how is this different?
Right.
Because we know there are neurotransmitters in the brain that either don't function well or there's a deficiency, like one of them, the most common one is we call serotonin, and we know how medicines help that.
Right.
And so I actually draw it out for them, that this is what's happening in the brain. It's and so, because parents will say, will my child get addicted to these medicines?
Right.
And again, not to sound very cocky, I said, does your child ever get addicted to penicillin?
Right.
And so, I'm trying to say this is a medical disorder. It needs to be treated just the way we would any other.
Well, and I think that those are important words for our viewers to hear. Clearly, there are many, many things that we could go on to talk about, but we do have a limitation of time. I certainly thank you for coming in to share your knowledge and expertise with us. I understand that you are leaving Johns Hopkins,
Yes,
and
I
you'll be moving on to D.C. as the chair of psychiatry at the Children's National Medical Center, and that if some of our viewers would like to get in touch with you there, that number is area code 202-884-3932. I want to wish you good luck in your work, and because I think we need more folks like you out there helping children and families. And I want to remind our viewing audience that if you or someone you know needs help with a mental health crisis, you can call Baltimore Crisis Response Incorporated at 24 hours a day. Thank you for tuning in, and remember, your mental health matters to us.